We now move into the newborn unit, and we begin with how the newborn adapts to life outside of the uterus. So, to begin to get an understanding of this newborn transition to extrauterine life, let's take a look back to where the fetus came from, or where the newborn came from. So, in utero, the fetus is totally dependent on the mother for oxygenation, for blood supply, everything. It's protected from injury, being enclosed in the uterus and surrounded by amniotic fluid. And the functions of the placenta basically were acting as the lungs. So the fetal lungs in utero are filled with fluid, and so they do not function as they do as a newborn or as an adult. Um, the placenta provided circulation, temperature regulation, again, nutrition, and excretion was all carried out through the placenta and amniotic fluid. And so there was a total dependency. And so going from total dependency to now having to independently doing these functions is remarkable, and it happens at the first breath. So I like to, provide multiple ways of learning material. And so I wanted to give a chart comparison of certain functions and how they relate to the fetus versus the newborn. And again, we'll go into many of these, such as the respiratory, heat, um, thermoregulation, and the fetal heart. So from this slide, I just want you to grasp the understanding that the infant must take over certain functions immediately. Like I said before, with the first breath, and that's respiration, circulation, and temperature maintenance. Other things, other adaptations from intrauterine to extrauterine life occur over a couple of days of life. So nutrition and fluid balance and elimination. And so there's going to require close observation by the nurse to make sure that these physiological changes or adaptations do occur. There are multiple stimuli at birth that affect the normal physiological change related to the respiratory system from a fetus to the newborn. Things such as external stimuli, sensory. So in utero, again, the fetus was protected and sounds were muffled. And now the sound of, you know, the voices, sounds of monitors, etc., can stimulate the brain that the newborn says, hey, now we're outside of the uterus, and so we should begin to take a breath. Thermal stimuli, changes in temperature. In utero, the temperature is warm and comfortable. Outside environment, depending on the temperature, will have an effect on respiration of that first breath. And then mechanical, there's a belief that during labor or during the descent and expulsion um, part of the cardinal movements, that there is a slight pressure on the thoracic cage, causing some of the fluid in the lungs to be removed. And so that would stimulate and allow air to now take over, oxygen now to take over those fluid filled spaces. Then there are internal stimuli, so chemicals. So a decrease in O2, causing an increase in CO2 and a decrease in pH, stimulates the respiratory center in the brain, in the medulla, causing signaling that a breath needs to be taken. So there's multiple factors that impact um, respiration at birth, that first breath. Here I provided a just a refresher about surfactant. We talked about surfactant during the antepartum period when we're talking about preterm labor and birth, and that we want to make sure that the lungs are mature, that there is surfactant present, enough surfactant present, so that the lungs do not collapse when that first breath is taken, thus decreasing the risk of respiratory distress for the newborn. It should be noted that some newborns have a brief period of increased respirations. The lungs are moist and you may hear crackles because, again, the lungs are fluid filled at birth, and with that first breath and subsequent breath, that the fluid is reabsorbed in the bloodstream. And so this transient period of increased respiratory efforts are more commonly seen with cesarean sections. Newborns who are born by cesarean section could be to the absence of that vaginal squeeze that I talked about of the thoracic cavity as the baby's being exposed, through expulsion under the symphysis pubis. And so some suctioning may be needed via a bulb syringe to clear some of the secretions. And again, this is temporary. Because breathing is new to the newborn, there may be periods of apnea where there is no breath, and it can be broken down into primary apnea and secondary apnea. Primary apnea is that there's no first breath, but it responds to stimulation. So baby may not come out crying or taking that first breath, but with vigorous rubbing or tapping of the foot, that it does, oh, I should take a breath. And so it has that first breath. And then secondary apnea, there is no response to stimulation. And so oxygenation is required. Babies experience periods of brief apnea in the first few days of life. And these are short periods, less than 15 seconds, where there's no breathing. They have irregular respiratory rates initially, but there's no change in their color, so they don't become blue or anything like that, because this is only a brief period as they start to establish a respiratory pattern. So know what primary versus secondary versus brief apnea is, how to distinguish between those three. When counting newborn respirations, you should know that normal respiratory rate is anywhere between 30 to 60 breaths per minute, and it's often irregular. And so when we're counting respirations, we should count for a full minute. Because of this irregularity, we can't do the count for 15 seconds and multiply it times 4, because they don't have a normal breathing pattern just of yet. And know that there are, again, brief periods of apnea, less than 15 seconds, and that the baby's abdomen and chest rise together, that we should see no seesaw movement with respiration, meaning that the chest rises but the abdomen doesn't, or vice versa. There should be one motion between the abdomen and the chest. We also should not see what we call retractions when the baby takes a breath in, that we see um, the rib cage. These are signs of seesaw movement, and retractions, along with nasal flaring, are signs of that the baby's having some difficulty breathing, or signs that indicate that there may be some respiratory distress. And so we want to monitor this baby, and along with checking the color of the newborn as well. Now, also a part of this immediate adaptation to life outside of the uterus are circulatory changes. And so, again, before birth, the placenta is the main source of oxygen and nutrients, and the fetal circulatory system is far different than newborn circulatory system, which is what we are more familiar with, the way the heart functions. And so I've provided two very detailed um, videos with visuals, about 10 to 13 minutes each, discussing fetal circulation before birth, in utero, and the adaptations and changes that occur to the newborn circulation after birth. And so want you to pay close attention to these two videos, and paying particular attention to the bypass vessels, ductus venosus, foramen ovale, and ductus arteriosus, and knowing when these shunts or these bypasses close, what causes that closure, um, and why there's no need any longer for these bypass vessels. You should also note and be familiar with, or know, that there are two arteries and one vein in the umbilical cord, and what the functions of these three vessels are. That the vein carries oxygenated blood to the to the newborn, to the fetus, and that the two arteries carry deoxygenated blood from the fetus back to the mother through the placenta. So again, look at both of the videos here regarding circulatory changes, and then in the subsequent or preceding slides, I've again given notes and just kind of recaps of what was discussed in those videos. So I won't talk on the following slides. They're just reiterating what is being said in the video. Because this is an extremely important concept to understand, I provided another source as a study tool, just uh, reviewing the fetal circulation and what happens before birth and after birth. Just as with the respiratory rate, the fetal heart rate initially is also can be irregular, and it should again be taken and counted for an entire minute. And you should know the normal range, again, anywhere between 110 and 160 beats per minute. Babies do have sleep cycles where their heart rate may be a little bit lower, and if they're crying or irritated, then that beats per minute can be as high as 180s. And we also, when we're doing our fetal assessment, or our newborn assessment, our newborn assessment, we want to check femoral and brachial pulses as well. And we'll talk about the newborn physical assessment in the next module. The last adaptation that needs to occur immediately has to do with thermoregulation. and the newborn's ability to heat itself and not become hypothermic. And newborns are prone to hypothermia because this heat regulatory system is not fully developed yet, and they have no shivering mechanism. So, when we get cold, we shiver to create heat, and newborns haven't developed that mechanism yet. So they have no shivering abilities yet. And then they have this large body surface area compared to their weight. When we think of premature babies, they have poor insulation, thin skin, the blood vessels are close to the surface of the skin, and they have less adipose, less fat tissue. And so the less mature a newborn is, the higher the risk of hypothermia. And so we want to make sure that we keep that in mind and know that the priority is to perfuse the brain and vital organs. So extremities are going to be cooler than the rest of the body. So when we look at newborns and do newborns assessments, the hands and the feet may be colder than the chest, because the chest comprises of or protects the main organs of the body. And so the hands and feet may be a little bit blue because, again, oxygenation and blood supply is to the major organs first and then out to the extremities. So to give some detail about thermoregulation, I've provided a link here again that discusses thermoregulation in detail and some of the key ways that the 4 ways that heat loss can occur, and how we as nurses can prevent heat loss by these 4 types of occurrences. So in the previous slide in that video, she talked about 4 mechanisms of heat loss. And so here I want to just discuss some strategies to prevent heat loss through these 4 mechanisms. So for conduction, which is loss of heat by direct contact of a cooler object, things that we can do is, one, making sure our hands are warm, because if we have cold hands, then the heat from the baby is going to transfer to our cold hands when we do our assessments. The stethoscope, making sure that the stethoscope is warm and that the baby is placed on warm blankets and not cold blankets. Heat loss through convection, when the air is cool, it will pull heat from the newborn, and so we want to make sure that the room temperature is normal, and that we keep that in mind, because a woman who is in labor or going through the 2nd stage of labor may be hot, and so we may turn down the temperature. But as delivery of the newborn is imminent, we want to make sure that we get that room temperature back up, turn on the heater under the newborn radiator, and making sure that that environment, the air is not cool. And so evaporation is heat loss through moisture. And so the main thing to do is to immediately dry the baby off. The baby can be put skin to skin to the mother if she's warm. That's another way of preventing heat loss through conduction, is putting the baby against its warm mother, and then we can wipe the baby off and get wet towels and get wet blankets off of the baby, and making sure that he or she is dry. And then radiation is not placing the baby near cool objects. So don't place the baby near a cool window, other things that may be cool. And so that's heat loss through indirect contact with a cooler object. And so there are various ways for nursing interventions that we can do to help with thermoregulation and to prevent heat loss through these 4 mechanisms. And so It's imperative that you know the difference between the four mechanisms and ways in which nursing interventions to prevent or decrease heat loss through these mechanisms. Persistent heat loss can lead to what we call cold stress. And cold stress is dangerous because now the baby has used up its energy stores to generate heat. And so I provided a link here to a video that again talks about hypothermia and cold stress and the use of what we call brown fat um, to generate more heat. And once brown fat is used up, there is no regeneration of that. And that in preterm babies, they have less, little to no brown fat. So again, putting them at increased risk for hypothermia. And so in this video, he talks about some of the effects, negative effects of cold stress on a newborn. Hyperthermia is less common than hypothermia in a newborn. And the key here is to differentiate between normal transient fever um, and a fever that's due to some type of illness. And so, nursing assessment and getting a clear picture of um, everything will help with that differentiation between normal transient fever and something more serious, like a sepsis or such. Moving on to other systems um, that require physiological changes related to the newborn being born um, is the urinary um, system. When you talk about voiding, a newborn should void within the first 24 hours. By the end of the first week, there should be at least 6 wet diapers a day. And this is important when we're discussing breastfeeding. How do moms know, or one of the signs they can tell that their newborn is getting enough milk and that it's staying hydrated is if it has at least 6 wet diapers a day. And this rule is usually taken into account a couple of days of life once milk supply is being established. So we tell moms upon discharge at home, they'll know um, that the baby is getting adequate feeding if he or she's having at least 6 wet diapers a day. And note that there, for the most part, the urine should be a normal pale yellowish color. That there sometimes can be a little stain, brick red stain on the diaper due to uric acid. But again, we want to make sure that we differentiate that from any other causes of bleeding. Is there any trauma to the vaginal area or to the penis area that would cause some bleeding? Here, I just want to point out that the stomach capacity of a newborn at birth is very small. And so, when we're talking about feeding, it's important to reiterate or even demonstrate to a family the size of the newborn's stomach and that it can't take on um, a lot of formula or with breast milk, the baby will stop when usually when he or she is full. Um, that the GI system is only able to digest simple carbohydrates and protein. So the use of rice or anything else in the milk is not beneficial because it's harder for the baby to digest, and you have problems with constipation or regurgitation. So Breast milk or formula, if that's what the mother chooses, is enough for the first 6 months of a newborn's life. One way to tell if the anus is patent is if there are stools. If the newborns had a bowel movement, and the first bowel type of bowel movement is what we call meconium, and it's thick, it's tar-like stool, and it contains bile pigment, remains of swallowed amniotic fluid, and then the stool changes now into a transitional stool, and it changes its color and consistency. And you'll know a difference between babies who are breastfed and those who are formula fed. Breastfed babies will start to have yellow mustard colored looking stools that are seeds. They look like they have little seeds, whereas babies who are formula fed have more formed, darker, harder stools. So the hepatic system of a newborn again is immature, and one of the key things that in nursing intervention is the administration of vitamin K. And we administer vitamin K to a newborn IM in the thigh within that first hour of life to help promote clotting factors. And we need to administer vitamin K because vitamin K is normally produced in the gut, in the GI system. But the newborn gut is sterile because it hasn't eaten anything. And Therefore, there's no bacteria there to help to develop and to create the vitamin K needed to help with coagulation. And so we'll talk about that again in the newborn assessment module, but want you to know that the newborn gut is sterile and that vitamin K is needed to help to stimulate the clotting factor or coagulation factors. Now we're going to move into another condition that can be normal in newborns, but also can have a pathological component to it as well, is what we call neonatal jaundice. And so we know that jaundice means yellowing of the skin. And so this is a physical manifestation of hyperbilirubinemia, where there is an abundance of unconjugated bilirubin that has not been picked up by albumin and moved into the liver to be discarded through the intestines. And so unconjugated bilirubin has now spilled over into the skin, causing it to have a yellowish tinge and even into the sclera of the eyes. Bilirubin is a waste product of red blood cells, and so when red blood cells get old and they die, usually 120 days or so, it breaks down into heme, where we have hemoglobin, and then there's this bilirubin. And in a normal process, the liver presents with albumin that takes up and conjugates this bilirubin and stores it until it is released into the GI system and excreted through either urine or more commonly through stool. And so now we'll talk about the various types of jaundice in a newborn and what we can anticipate as far as nursing care or interventions related to these different types. So there's 4 types of neonatal jaundice, and in this module we'll talk about the first 3. Physiologic jaundice, breastfeeding jaundice, which usually has an early onset, or breast milk jaundice, which has a late onset. And then we'll have a separate module talking about pathological jaundice and its causes and how we treat it. Most newborns, somewhere around 60% of all newborns, will have some level of physiologic jaundice. And this is usually benign. And this occurs because of the liver being immature. And so then the immature liver therefore doesn't have enough albumin to keep up with the breakdown of red blood cells. Newborns have way more red blood cells than we do, and so there's more red blood cells that are being that die off, and so there's more bilirubin that needs to be conjugated. And so if you have an immature liver that isn't producing enough albumin to keep up with this already high level of red blood cell hemolysis, right, if you will, breakdown of red blood cells, then you're going to get this physiological jaundice. And so it usually resolves itself as the liver begins to mature and once the baby starts to eat. And so it peaks around 72 hours and resolves with increased feedings, which increases that newborn stool. And so the key to know is that physiologic jaundice is common, and it occurs after the first 24 hours of life. Breastfeeding jaundice usually begins around 2 to 4 days of life for the newborn. And it occurs when the mother has to be breastfeeding and when there's no other cause found for the jaundice. And so it's not related to breast milk, but it's more that the newborn is not getting enough breast milk, therefore not having enough stools to be able to excrete the unconjugated bilirubin out. And so what we would have moms do is to increase the amount of feeding that they're doing, making sure that they're feeding for at least every 2 hours, and watching the positioning and latch of the newborn and how long the baby's on the breast, that there's adequate milk production and that the baby is being well fed. Breast milk jaundice is rare and it has a late onset. So it usually peaks around 2 weeks of life in an otherwise normal breastfeeding newborn. And there's theories out there related to why this occurs, that there may be that breast milk may inhibit conjugation or excretion of bilirubin. But again, the diagnosis is made in breastfeeding newborns who are otherwise healthy, that there is no other cause of the jaundice being noted. And so what we want to make sure is that we do not tell moms to discontinue breastfeeding, but in fact to continue breastfeeding. Baby may need some supplementation, but do not discontinue breastfeeding. We want to assess how the breastfeeding is going as opposed to telling the mother to stop altogether. Here again, I just wanted to provide a review as an extra method of reinforcing neonatal jaundice, and particularly looking at the first type of jaundice, physiological jaundice, and then this video also talks a little bit about pathological jaundice, which again we'll get into greater detail in the hyperbilirubinemia module that is coming up. As you may have guessed, that the immune system of the newborn is immature, and here I've listed some common immunoglobulins, IgG, IgM, and IgA, and how they relate to newborn immunity. And for example, IgG crosses the placenta, and what impact that has on the fetus and the newborn. Now we're going to move to variations in the newborn skin. And this is part of our nursing assessment when we're assessing the newborn, looking at what's normal adaptations or changes in the newborn skin. And this is also a good opportunity for teaching, because if there's any variations in the newborn skin, the family's going to be aware of that. And so you want to provide information regarding what's normal, how long things last, if they need to do anything to the skin as well, or what these variations mean. So when we're doing our assessment of the newborn skin, we want to keep in mind what's normal for that race. We know that various races have different pigmentations, things like that. We want to look at the skin for yellowness, any yellow tinged skin, which would indicate jaundice or could indicate jaundice. Two terms we'll talk about: acrocyanosis and sarcomal cyanosis. Is the skin moist? Is there Vernix? Is there Lanugo? All those things we'll discuss in the following slides. And so many of these variations are self-explanatory, meaning that the information that I have on the slide, I don't need to repeat. So I won't be talking over every slide, but keep in mind that you should be able to differentiate based on the characteristics of these skin variations, be able to differentiate between the variations. There are some normal and abnormal skin changes due to the lack of oxygenation that occurs early in the newborn life. And so two terms that you should know and be able to differentiate between the two is acrocyanosis and sarcomal cyanosis. So with acrocyanosis, if you recall earlier, I mentioned that the priority for providing blood to the body starts with the major organs, the brain, the heart. Those things need to be perfused first, and that the extremities, the hands and the feet, are last. And so because of this poor or immature peripheral circulation, early in the newborn's life, you may see where the hands and the feet are not pink compared to the trunk and the rest of the body. And so this is acrocyanosis, and this is a normal phenomenon that doesn't usually indicate that there is some oxygenation issues. It's just mainly because of a immature circulatory system that's being established. On the other hand, sarcomal cyanosis is when there's blueness around the mouth, okay? And this signals that there is some oxygenation issue that needs to be addressed, that the body there's some issues with the circulatory system that's not related to simply being immature. And so many times when we see sarcomal cyanosis, blueness around the mouth, we want to observe this baby. What was happening when this happened? Was it during feeding? Is the baby showing any other signs? Are there retractions? Are there nasal flaring? What's the respiratory rate? Is there any seesaw movement as opposed to that uniformed up and down movement between the chest and the abdomen? And so I also mentioned that some races and ethnicities have variations in pigmentation. And one of these extra pigmented areas is known as Mongolian spots. And they are benign bluish pigmentations that's usually on the back side of the newborn. So over the butt, over the lower legs, and mainly seen in darker skinned races and ethnicities. So African Americans or African, um, Mediterranean descent, and usually disappears over 2 years. And so I wanted to point out Mongolian spots because if you look at the picture, that those can be mistaken for bruising, right? And so we have to again be um, aware of the fact that Mongolian spots do exist, but still do an assessment to make sure that it's not um, any bruising. And so Mongolian spots are not painful to the touch. Um, that we should investigate, especially if we're doing a late postpartum, a late newborn assessment upon return from hospital discharge. You want to talk to the parents about what Mongolian spots are, and that they can relay this to other support persons or other providers who are going to be caring for the baby, knowing the difference between Mongolian spots and bruising. Next, I want to bring your attention to two um, skin variations that are of importance: Vernix and Lanugo. So Vernix is a cheesy appearing substance covering the body, and Vernix protects the newborn skin in utero from amniotic fluid because it can be acidic or dry out the sensitive newborn fetal skin. As the fetus matures in gestation, there's less vernix because again there's less amniotic fluid, and so um, and the skin becomes a little thicker the more mature the fetus is, and so it's a mixture of cells that's flaked off from the skin and fatty substances from sebaceous glands. And Vernix absorbs easily into the skin, so it's kind of almost like lotion. All right, um, and so when we see a baby with Vernix, this can be an indication of gestational age. We can kind of guesstimate, is this baby preterm or term or post-term, depending on how much Vernix is there. So the more cheese or the more Vernix we see on the skin, the less likely this baby is term. Okay. Um, so term infants may have little to no vernix. Babies who are past 42 weeks will have no vernix. Those who are less than 37 weeks will have more vernix. And so, so those are things to be aware of when we're doing a newborn, um, when we're in the labor and delivery unit and we admit a patient and she's coming in for either she's in labor or she's being induced, what have you, and we get report that she is term, at least 37 weeks, and then upon delivery, this baby comes out and he's full of vernix. That signals to us that more than likely the dates were off and that this baby's not 37 weeks and that we in fact are dealing with a preterm baby. And then that leads us to, change our assessment, because those things that come with being premature, respiratory issues, thermoregulation, those types of deals, that would signal to us. So it's important um, to pay attention to the amount of Vernix seen on a newborn, and that we don't vigorously have to wipe it off. Again, it reabsorbs into the skin. We're wiping more so to prevent heat loss from evaporation, wetness, right? So the next skin alteration that you may see is lanugo, which is fine downy hair on the face, the back, and the shoulders that usually sheds in the first week. And again, this is age appropriate. So the more lanugo you see, the less likely this baby is term. Okay, and with lanugo, we want to also take cultural considerations into account, and that some cultures, babies are hairy. So, for instance, Hispanics, you may see more hair on the baby, and that is not an indication of prematurity, but more of a cultural characteristics. So again, looking at the whole picture, okay, before we jump to um, assumptions. Milia are tiny white papules that we see over the nose and cheeks. They look like little pimples. And this is, they form due to an obstruction of the sebaceous glands. And so no treatment is needed, it's self-limiting, and that's what you want to pass along to parents, that they don't need to pop or squeeze the milia, because it's not a pimple, and we shouldn't be popping pimples anyway, but that it's a normal appearance or variation that will disappear or correct itself over time. Next, I'm going to talk about acquired soft tissue injuries. And acquired is different than congenital. Congenital anomalies are conditions that develop during the development of the fetus, and acquired means that there is something, a condition that caused, or an injury that caused the abnormality. So again, a brief overview or review of the newborn head, and particularly talking about the fontanelles. And remember, the fontanelle are those spaces anteriorly and posteriorly where the newborn or fetal skeletal plates come together, and where the sutures come together, suture lines come together. And so again, we have an anterior fontanelle, which we usually lay terms refers to that soft spot at the top of a baby's head, and then a posterior fontanelle, which has more of a triangular shape in the back of the head. And so when discussing, when these closures occur, usually the anterior fontanelle, the soft spot, takes longer to close compared to the posterior, which I've indicated here. So again, good teaching for parents and letting them know that, these sutures and fontanelles will all close, and that the skull then becomes a fused bone. But we'll talk about some significance with the anterior fontanelle when we do a newborn assessment. So if you recall, when we talked about the cardinal movements of labor that the newborn had when we're talking about the fetal skull is that the reason that the fetal skull is not fused as ours are is because of the need for it to mold, right? And so molding is that overlapping of bones of the fetal head to allow for passage through the passageway, through the pelvis. So the purpose is so that the head can fit, right? And so molding can leave a fetus, a newborn upon delivery with a quote unquote cone or elongated shaped head. And again, um, the type of molding or the severity of the molding depends on, you know, how long the mother was in labor, the position of the baby, etc. And birthing method. If a woman has had a cesarean section without any labor, if she's had a repeat C-section, there may not be any molding because there was no labor and the fetus was not descending down. And so the newborn head may not have this cone or asymmetrical looking shape. If the labor was long, on the other hand, and that there was a lot of, that the labor may have been protracted and she needed augmentation, there may be more molding. And so, again, it is important to teach when you're doing a newborn assessment to inform the family of what's normal and that newborn molding resolves in a couple of days and that there's nothing that they need to do. You may hear in some cultures, for example, my grandmother believed that they needed to shape the baby's head. You know, if it didn't come out a round, nice round head, that they would, you know, take their hands and rub over the baby's head for long periods of time in attempt to quote unquote mold it. Were they molding the head? No. This is just a process that resolved on its own. But culturally, you may find grandmothers or mothers who believe that, and so it's nothing harmful. You know, they're just rubbing the top of the head. So two acquired soft tissue injuries that you must be aware of and be able to differentiate are caput succedaneum and cephalohematoma. And we'll talk about these two each individually on the next two slides. Caput, for short, is this diffuse swelling or edema due to the pressure placed on the fetal scalp during labor. And so what we find is a collection of fluid that is in between the scalp area, right? And that there's no treatment needed, that it's spongy, and it does cross suture lines, okay? And so again, if you're going back to the fetal head anatomy, that there are sutures in between the fetal bone plates. And so this fluid crosses the suture lines, and that's one of the differentiating factors between caput and cephalohematoma. Where caput was an accumulation of fluid, cephalohematoma, the word hematoma is meaning blood, is an accumulation of blood under the periosteum of the fetal bone or the newborn bone. And so it's not blood collection on the brain. There is a collection of blood above a thin layer of the fetal skull or the newborn skull. And this occurs usually due to some type of trauma during labor and delivery, particularly during birth. For example, the use of forceps can increase a newborn's risk of acquiring a cephalohematoma. The cephalohematoma does not cross the suture line. It stays in the periosteum area of one particular bone plate. Okay, so if it's in, if you have a cephalohematoma in the right on the right frontal plate, it's not going to cross that suture line and extend or cross over into the left frontal suture plate. It stays in its area, whereas caput crosses the suture line. So it's extremely important to know that differentiation, and that cephalohematoma is an accumulation of blood, where caput is an accumulation of fluid, and both will be reabsorbed. However, with cephalahematomas, we have um, the potential for jaundice, and not physiological jaundice, but pathological jaundice. And this jaundice occurs because we mentioned that the newborn already has an increased amount of red blood cells that the immature liver is not able to keep up with conjugating bilirubin, which is a byproduct of red blood cells. So if we have more blood collecting in this area because of cephalohematoma, now we have even more red blood cells that will be broken down, and more bilirubin that will be unconjugated. So cephalahematomas put babies at risk for jaundice. And so if we have a baby who has cephalohematoma, jaundice should be, along with other things, should be in our head when we're doing assessments, or as we're watching this newborn. Again, it does not affect the brain, and that you tell families that this will resolve over weeks, and it may take some months before this reabsorption and breakdown of red blood cells. Here I provided a visual showing the difference between the collection of fluid and blood between caput and cephalahematomas. And as you can see, if you see more uniformed swelling, then that's a caput. If there is swelling on one side, it's caput. And again, knowing the delivery history can also help with differentiating between the two. If there was a report that there was an operative vaginal delivery, that there were forceps used, or that there was a vacuum used, and that, so if we see swelling, that most likely it's related to a cephalohematoma, or if the woman was pushing for a while, or she stayed at 10 centimeters, or stayed at 8 centimeters or whatever for a while, that we can anticipate a caput. Can you have both? Sure. You can have a woman who had she pushed a long protracted second labor, and then the decision was made to use forceps, and so she developed caput, and then by the use of forceps, a cephalohematoma developed. It's important that you know the different newborn reflexes, because that's an indication of normal CNS, central nervous system functioning. There should be good muscle tone and posture. The newborn is in the fetal position, body is flexed. Again, that flexion of the legs and arms are to decrease the body surface in an attempt for thermoregulation, right? And so the more mature or term a newborn is, the better the posture, the tone, and the reflexes are. And so, we want to note if there's any flaccidness or floppiness to the newborn, which is abnormal. Is there partial flexion or extension, which is more common in preemies? Is the baby jittery? And are the tone and movements symmetrical? And then on the right hand side here, I've listed newborn reflexes that you should be familiar with. So the Morrow reflex, to test that, we would have a baby lying supine, and we would hold its arms, and you let go of the arms and the baby is startled and the arms would kind of flare out. Rooting, if we use with a gloved hand, you're checking the roof of the baby's mouth and it begins to suck. Or if you see a baby at the breast and it's sucking, you know that the rooting reflex is intact. Palmar and plantar grasp. So palmar grasp is when we can take our index finger, put it in the middle of a newborn's palm, and the fingers should try to grasp your fingers. The newborn fingers should come in to try to grasp your fingers. And so the same can be done with the plantar. If we push in the middle of the baby's foot, its toes would curl in an attempt to grasp the finger. Um, Babinski reflex is a reflex done at the bottom of the foot. If we touch along the side of the fifth digit, the toes should fan out. Okay, and then the crawling reflex, where babies make crawling, or the stepping reflex, where babies, if you hold them up, they make a stepping, like the legs will start to move. Keeping with the central nervous system, let's talk about periods of reactivity. So these are time periods where the baby is either alert and responsive or sleep. And so here I've listed the initial period of reactivity time, which lasts about 30 minutes of first 30 minutes of the newborn life. And so again, this is a good opportunity, a time if the mother is planning to has plans to breastfeed, that we initiate breastfeeding early, because this baby is going to be responsive within that first half an hour of life. Otherwise, it goes into this diminished activity and sleep cycle. And so it may be more difficult to start breastfeeding later as opposed to earlier. And then the baby gets a second wave of reactivity that will last up to several hours, where again, he or she is awake and alert. So the initial period of reactivity is an opportune time to initiate breastfeeding, to begin the attachment process between caregivers, parents, and the newborn as well. There are several behavioral states of a newborn that, again, is important for parents to know, and that discussion can happen when, again, you're doing your newborn assessment and teaching, and knowing that babies have at least 6 behavioral states. They can be in a deep sleep, in active light sleep, where they are asleep but they're easily aroused, or they can be drowsy, where you see them nodding off. Quiet alert is where they are just kind of looking around, taking in the environment, the sounds uh, of the environment, and not making much noise. They may be cooing, not making much noise. And then they move into the active alert, where their extremities are moving around, and their heads are moving side to side, and they're a little bit more active, and then crying. And it's important to know these behavioral states. Again, knowing what's normal, and that what times are the best times to initiate things, to do feedings, to do assessments, things like that. And so we want to integrate this into our education and prep for discharge plan. And know that babies sleep. They sleep 16 to 20 hours um, a day, for long periods of time. And we know that that changes. They don't go to sleep at night um, all the time like we do, because they're sleeping during the day. So, again, helping parents to prepare for this adjustment.